I am Sharita Edwards. I am a Doctor of Nurse Anesthesia practice student at Virginia Commonwealth University. Today, I am presenting retained gastric contents in an anesthetized patient prescribed semaglutide for weight loss during a colonoscopy and EGD, a case study. Obesity is a complex medical condition that disproportionately impacts morbidity and mortality. Recognized as a disease in 2013 by the American Medical Association, obesity is defined as a body mass index greater than 30 and is associated with serious comorbidities including heart disease, diabetes, sleep apnea, and certain cancers. Data from the Centers for Disease Control reports that 1 in 3 Americans is obese. Therapies aimed at managing obesity have gained recent popularity, including the use of glucagon-like peptide receptor agonists. Originally used as an adjunct in treating type 2 diabetes, the use of GLP-1 receptor agonists as a weight management medication for the non-diabetic obese patient has exploded. It has also increased in a weight management medication for those people who are only mildly overweight. GLP-1 receptor agonists bind to receptors in the hypothalamus that mediate hunger. They also enhance lipolysis, which is a process by which your body releases fat from fat cells. On the slide, I have a list of how the GLP-1s that are now approved by the FDA are categorized. They're categorized as either short-acting or long-acting. The short-acting tend to be given by mouth, while the long-acting tend to be injected medications. Delayed gastric emptying results in decreased appetite, decreased calorie consumption, and increase in feeling full. The half-life for most of the injectable medications is about 7 days, and the daily oral medications is about 1 day. I've listed the side effects of these GLP-1 receptor agonist medications, and they are important for anesthesia, or they have anesthetic complications due to delayed gastric emptying and the increase in retained gastric contents and also nausea and vomiting. GLP-1 receptor agonists gained traction for weight management when the FDA approved liraglutide in 2009. In 2020, as many as 5 million prescriptions for semaglutide alone were written in the US. The availability of these medications online have increased the access. Due to the mechanism of action, these patients are at increased risk of pulmonary aspiration of gastric contents. Unexpected retained gastric contents and increased incidence of pulmonary aspiration of gastric contents in patients without any other predictors than the use of GLP-1 surface in the literature in around 2022. The ASA and now the AANA have practice recommendation, but the assimilation into practice is varied by clinical site. An additional anesthetic concern is that when we receive a history and physical from referring primary care physicians for the colonoscopy outpatient clinic, we get a list of medications that the provider knows that the patient is taking. However, now with the increased access of online prescription for GLP-1s, some of these patients may be taking these medications prescribed by some of the online online pharmacies and physicians listed on this slide. That information may not be told to the primary care physician, and we might not know that they are on this medication because it's not on their current medication list. This slide contains a brief synopsis of the case study that I am presenting today. A female patient presented to our colonoscopy clinic for a screening colonoscopy and a diagnostic EGD or esophagogastroduodenoscopy related to symptoms of heartburn. Total intravenous anesthesia was administered and the EGD scope inserted. Upon examination, a large amount of solid food was noted in the stomach. The scope was withdrawn and the procedure was terminated. The patient was allowed to emerge from anesthesia without complication, and it was explained that she had a full stomach and that she would need to reschedule her procedures. Discharge instructions were given to the patient, and also a medication reconciliation list was handed to her. And on her review of her medication list, the patient reported that she had forgotten to include her semaglutide 2.5 milligram injection that she received from a compounding pharmacy online to manage her weight. She reported that her last injection was approximately 2 days prior. The patient was encouraged to not take her next dose of semaglutide and to reschedule in 5 days and to follow the same pre-op instructions to prepare for her repeat colonoscopy EGD. She returned the following week and followed the same fasting protocol, and she was prepared in the same manner as before, and we were able, the scope was inserted, her stomach was able to be visualized, and we completed both the EGD and colonoscopy without incident. The case was presented at the quarterly procedure suite meeting with a recommendation of creating a policy regarding GLP-1 medications. The endoscopist then updated procedure preparation instructions with including withholding of GLP-1 medication for 7 days before scheduled procedures. Case presentation. This patient was a 48-year-old female whose occupation was an elementary school teacher. She weighed approximately 280 pounds. Her height was 5'6", ethnicity Black or African American. Her chief complaint was that she had some frequent heartburn and was overdue for her screening colonoscopy. She denied rectal bleeding, constipation, diarrhea, change in bowel habits, nausea, or bloating. She completed a 24-hour liquid diet followed by a colon preparation as prescribed with Miralax and Gatorade. The EGD was attempted but was aborted after there was visualization of solid food in her stomach. Upon discharge, the patient reports use of semaglutide injection from an online pharmacy. The colonoscopy and EGD were completed without incident after 7 days abstinence of GLP-1. Recommendation of holding GLP-1s for 7 days for non-diabetic patients added to agenda for the next Board of Managers meeting, quarterly meeting. At that time, our center did not have a policy for GLP-1s. We now currently do. Past medical history for this patient included fatty liver, high cholesterol, and depression. She had a surgical history of a liver resection 5/2023 and C-section times 2, one in 2006 and the other in 2008. Her past anesthesia history was negative for any anesthetic complications, including postoperative nausea, vomiting, difficult airway, and delayed emergence. There were no prior diagnostic studies. Her medication list included Effexor and Lipitor. She denied any known drug allergies. Patient denied any use of alcohol, tobacco, or recreational drugs. In regards to her family history, her mother is alive and well with a history of heart disease and breast cancer. Her father is alive and diagnosed with colon polyps, and her grandfather is deceased and he was diagnosed with colon cancer before his death. Her psychosocial history included a non-vegetarian, low-fat diet. She reported 2 days a week that she walked for 20 minutes. Her genetic information was not available, and she was middle class. Her pre-anesthetic assessment was as followed. She was generally healthy looking, in no acute distress, pleasant, obese female. Her vital signs are reported on the slide, including a BMI of 45.19. Our cutoff for BMI at our facility is a BMI of 50. Her airway assessment, she was noted to have a mouth opening greater than 2 finger breaths. She had a Mellon-Potty grade of 2, a thyromental distance greater than 3 finger breaths, and her dentition was intact. I did not anticipate that she would be a difficult airway. She had a normal respiratory effort, normal breath sounds, and she had a normal sounding S1, S2 without gallops, murmurs, no pitting edema or cyanosis. She denied nausea, vomiting, heartburn, reflux, or abdominal pain of any kind. She had normal liver function, normal renal function, and normal endocrine function. After the assessment was complete and the nurses had reviewed and confirmed that she had complied with the liquid diet as well as the prep instructions, then her anesthetic plan was proposed, which was total intravenous anesthesia. We used propofol. She was given an ASA grading of 2, and her procedure was an EGD followed by a colonoscopy. That was the plan. This slide is the pre-procedure preparation and timeline. So at 9:15, the patient was admitted by the admitting RN, and her health information was reviewed. She was asked questions regarding her prep, and she was explained the anesthetic risk and benefit by the anesthesia provider and the procedure risk and benefit, and she signed both the anesthesia consent and the procedure consent, and at which point a number 20 gauge IV was inserted into her right hand, and normal saline in a 500 ml bag was hung. The pre-anesthetic assessment was done, as again her consent was given, and I went through pertinent negatives with her from all body systems. We talked about her surgical history, and she denied a history of postoperative nausea, vomiting, like I had stated before. And she was then asked if she had any questions and then transported to the procedure suite. At 9:45, she arrived in the procedure suite, and a nasal cannula was applied and connected to our oxygen source at 4 liters per minute. Routine monitors, a 3-lead EKG, non-invasive blood pressure cuff were placed along with a pulse oximeter on the same side as her IV. We did a timeout at 9:49, and the patient was positioned, well, she positioned herself in left lateral decubitus position with the head of her bed elevated to 45 degrees. A bite block was placed and secured, and she was asked to take several deep breaths. At 9:50, lidocaine 20 milligrams was administered via IV bolus, followed by propofol 70 milligrams IV bolus. At 9:52, the scope was inserted through the bite block and advanced down the esophagus. Once the scope was inserted into the stomach, there was noted obvious retained gastric contents, solid food. The scope was advanced a little further just to see if we could view the pyloric to rule out pyloric stenosis, and that was ruled out. At 9:55, the examination was terminated, and the patient was allowed to emerge from the anesthetic without incident. She was taken to recovery, where she was alert, awake, and responsive. The bite block was removed. I was not permitted to use the actual video of the retained gastric contents, but this picture taken from the source that I've listed below was almost an exact replica of what we saw when we entered her stomach. And again, she was taken to PACU with the head of her bed elevated 45 degrees, spontaneously breathing with airway reflexes returned. Once the patient was awake and dressed with her family member in the room, it was explained to her in detail why her procedure was canceled and why we had to stop her EGD. The nurses gave her discharge instructions, which included rescheduling her procedure, and also gave her a list of medications and directions for what she should eat once she left. Upon review of her medication list, the patient reported that her semaglutide injection was not included on the list. And when asked when she had last had her semaglutide, she reported that she had just done her injection of 2.5 milligrams 2 days prior. Myself, the CRNA, and the physician were notified, and we spoke with her, and we recommended that she hold her semaglutide and return in 5 days. The physician told her to do the same liquid diet with the same prep instructions with the Miralax and Gatorade. She did that. She returned to the clinic 5 days later and did not take her semaglutide dose. She was prepared for the procedure in the same manner as before. She gave consent for the procedure and anesthesia. She was taken back to the procedure suite, the same monitors, the 3-lead EKG, the non-invasive blood pressure cuff, and the pulse oximeter, as well as nasal cannula of 4 liters per minute were applied. She was placed in left lower decubitus, and her EGD scope was inserted through the bite block after receiving 20 milligrams of lidocaine and again a 70 milligram bolus of propofol for insertion of the scope to the stomach. We were able to visualize the stomach because there was no solid food or retained gastric contents, and her EGD proceeded without complication. And then we moved on to the colonoscopy that was completed without incident. She received a total of 300 of propofol for the entire case that lasted approximately 25 minutes. She was allowed to wake up, taken to recovery, and discharged with instructions without incident. One of the strengths of this case study was that the patient had no other predisposing factors for retained gastric contents except for the use of GLP-1s. She was not a diabetic, and she did not have a known history of delayed gastric emptying. It is also curious that she had been on a liquid diet for a number of days and still had retained solid food after a bowel prep. Another strength was that the patient was able to reschedule after 5 days and follow the same fasting protocol with the same medications, and we could evaluate the effectiveness of holding the GLP-1 for the recommended 7 days. Limitations of this study included picture documentation was not available for me to use for the case study. At our facility, we do not have point of care ultrasound, so we did not have an ultrasound for visualization of gastric contents before and after the procedure. And although the patient was told to repeat the same fasting protocol, it is possible that she extended her liquid diet for longer than she was told to make sure that her stomach was empty. So there needs to be more research in this area specific to anesthesia and specific to non-diabetic patients who are using GLP-1s for weight loss management. So where we are now, there are current recommendations for preoperative management for patients on GLP-1s. That includes increasing fasting guidelines. To date, there's a lack of consistency on what those increased guidelines should be. There's also the recommendation of using perioperative prokinetic medications, but there is no consensus on which one of these, what combination of these, or how much. The recommendation is also to conduct a preoperative ultrasound assessment of gastric contents, which is not available in many areas. The ASA and AANA list the following recommendations which I documented from their websites. For daily dosing, hold the GLP-1s on the day of surgery. For weekly dosing, hold the GLP-1 a week prior to surgery or procedure. There is a lack of research to show direct correlation of GLP-1 and the relationship to pulmonary aspiration. One research study from 2023 presents a case of retained gastric contents in a 30-year-old patient taking semaglutide, but also notes that the patient may have had gastroparesis related to diabetes. Another study in 2023 showed that fasting patients on semaglutide had approximately 5 times the risk of having residual gastric contents compared to those not on semaglutide. While another study in 2021 conducted with a larger cohort showed perioperative use of GLP-1 agonists were not associated with retained gastric contents in those patients undergoing an EGD. So there is conflicting research, and there needs to be more specific research for patients on GLP-1 receptors agonists strictly for weight loss management, including those who are obese and those who are of normal weight and on these medications. Thank you for listening to my case presentation. This page is a list of my references, and again, thank you so much for listening to my case study.